Hi, my name is Natalie Shefwa, and I'm a student physical therapist who's been working at the Marquette PT Clinic this past 10 weeks. And today I'm going to be presenting on physiotherapeutic scoliosis-specific exercises and other treatments for scoliosis, with the intention of introducing you to some unfamiliar treatments of scoliosis and some that you've probably also heard of. So idiopathic scoliosis is a 3D torsional deformity of the spine, primarily a frontal plane curvature. So you see sort of a side bending deformity with a rotational deformity to the same side, and often a lordotisation or flattening of the back. The etiology of scoliosis is unknown, although we do know there's both a genetic component to it, as it does travel in families, and an environmental component to it, as there's some correlation to latitude. The prevalence of scoliosis is 2 to 3%. We consider someone to have scoliosis when they have a Cobb angle of at least 10 degrees. Now, it's widely known that girls have scoliosis more often than boys, but in truth, when the Cobb angle is between 10 and 20 degrees, there's an equal prevalence between boys and girls. It's not until the Cobb angle is greater than 20 degrees that you see a 5-fold increase in girls, and greater than 30 degrees, a 7-fold increase in girls. Now, the risk for scoliosis is the risk for progression. Patients who are most at risk for progression will be female, just hit a growth spurt, and have a larger Cobb angle to begin with. Patients with a Cobb angle of 10 degrees will have a 2% risk for progression, of 20 degrees, a 20% risk, and of 30 degrees, a 30% risk. The danger of progression is that once that Cobb angle reaches somewhere between 30 to 50 degrees, the patient reaches a critical threshold. And at that point, we know that there's a higher risk for health risks in adulthood, a decreased quality of life, visible deformity, a visible disability, functional impairments including decreased exercise capacity and respiratory function, and pain. Scoliosis patients are twice as likely to have chronic pain and 20 times as likely to report severe and darting pain if left untreated. So our goals for treatment then will be to stop or reduce progression at puberty, to prevent or treat respiratory dysfunctions, prevent or treat spinal pain disorders, and improve aesthetics. The way that these patients look is very important to them, and the deformity is correlated to function as well, so the way they look is actually a goal for us. There are 5 basic treatments for scoliosis currently, the first being just observation, sort of a wait-and-see approach where the patient gets an x-ray initially and then maybe a follow-up every 6 months to a year until they stop growing. There's also bracing, surgery, non-specific physical therapy, and physiotherapeutic scoliosis-specific exercises. And we'll talk about those last 4 in more detail. So bracing is indicated when a patient has a Cobb angle greater than 25 degrees and they're still growing. Studies show that rigid braces are more beneficial than flexible braces, but this all depends on the dosing. The braces should be worn at least 18 hours per day, sometimes up to 23 hours per day, depending on the severity of the curve, the stage progression, the patient's compliance, etc. It has to be worn until the end of vertebral growth and then weaned gradually. Now, studies show that this does not reduce the frequency of surgery, but it does improve that risk for progression. Now, because these braces are uncomfortable and not very aesthetically pleasing, compliance can be an issue, so you want to keep that in mind before prescribing this. And as far as physical therapists are concerned, anytime you immobilize a body part, we're risking atrophy of the musculature, and that's the opposite of what you want in scoliosis patients, so they should be doing some activity even while in the brace. Surgery then becomes an option when the Cobb angle is greater than 45 degrees. I'm not going to go into all the details of the different surgeries, but they often involve Harrington rods and pedicle screws. They've been shown to improve the coronal plane deformity anywhere from 30 to 90%, which is kind of a huge range. But this isn't an easy solution either. There's a risk of reoperation, risk of infection, and there's an extensive recovery time, 3 to 4 weeks before the patient returns to school, and 6 months before they can return to full participation in their previous activities. Furthermore, there have been no studies comparing long-term surgical outcomes to long-term conservative treatment outcomes, so we still don't know if in the end this is the best option for our patients.
Hi, opportunity.
So this brings us to non-specific physical therapy. That's what you typically think of with outpatient orthopedic physical therapists, like the ones we have at the Marquette PT Clinic. They'd be working on things like range of motion, strengthening, modalities, manual therapy, functional training, balance, pain management, anything you can think of to improve quality of life and the function of the patient. This is a really nice option because it can be used with or without bracing, with or without surgery. So it's available at all times during this disease progression. Now, it's also recommended by the Society of Scoliosis, Orthopedic and Rehabilitative Treatment to include aerobic training, partially because we know that aerobic training has great benefits for almost every patient population, but also because scoliosis patients have respiratory dysfunctions. Now, unfortunately, the Scoliosis Research Society just published a study a few years ago where they interviewed Scoliosis Research Society physicians on their prevalency of referral to PT and PSSE, and a whopping 63% did not refer to PT or PSSE. The reasoning for doing so is a lack of evidence, no value, or inaccessibility in the case of physiotherapeutic scoliosis-specific exercises. Now, physical therapy outcomes can be pretty hard to measure because there are so many different treatment options and no PT will treat the same way. So when we look to the evidence, sometimes the physiotherapeutic scoliosis-specific exercises gives us more detail that way. Which brings us to PSSE. This is sort of a general term for 7 different schools of thought, mainly in Europe. Each of these schools is a physical therapy treatment that specifically treats scoliosis. Typically, they each have their own brace and their own classification system for the types of scoliosis. They're often a multidisciplinary approach, so these PTs would be working along with physicians and sometimes even psychiatrists and family counselors. These schools require extensive training on the part of the physical therapist. So your average PT, especially in the United States, is not trained in PSSE. That's a separate certification you would have to look for if this is a treatment that you're interested in for your patients. The dosage is actually very similar to regular PT, anywhere from 2 to 7 days per week, depending on the patient's complexity, the type of treatment, etc. The research for this is very good. It's been shown to improve or reduce Cobb angle depending on the school. And it's also been shown to reduce surgical prevalency when paired with bracing, regardless of the type of brace used. Furthermore, it gives families an option for treatment other than observation and waiting for bracing. 87% of families reported they preferred PSSE over that observation approach. So when we're talking about PSSE, there's sort of 4 general principles you'll see in each of these schools. The first being 3D self-correction, then training activities of daily living, stabilizing that corrected posture, and patient education. So as I mentioned, there are 7 different schools of PSSE, dating as far back as the 1800s and as recently as 2004. All of these schools came from different countries in Europe, so it's a very popular treatment option in Europe, but it's less well known in the United States. So my goal for you guys today is to go through each of these 7 schools in a little bit of detail, and then show you some sample exercises, the types of treatments that you would see with these treatments. So the first approach to come about is the Lyon approach. It's based on the vicious cycle, which is the concept that some environmental trigger causes a wedge-shaped vertebra to grow. That wedge-shaped vertebra puts asymmetrical stresses on the rest of the spine, so the spine then grows asymmetrically. As it continues to grow asymmetrically, there are then asymmetrical forces placed on the rest of the spine, and you see how this just keeps going. So this approach tries to disrupt that cycle. It also uses something called rotational angular breathing, which is a common technique that you'll see throughout the different schools of PSSE. Rotational angular breathing is when the patient is cued to breathe in through the concave side and out through the convex side, to sort of twist the rib cage from the inside out using the pressure of the lungs. Something unique about this approach is that it avoids sagittal plane extremes, so you don't see much flexion and extension in the trunk. You also avoid shortness of breath. It is not supported for patients with a Cobb angle of less than 20 degrees, and it gets most of its effectiveness when paired with bracing and casting. So if you think about the patients who will benefit most from bracing, they're going to have the larger Cobb angle and still be growing. Then came the Schroth method, which uses the body blocks classification system. So these physical therapists will look at the shoulders, the thoracic trunk, the lumbar trunk, and hips separately. In a healthy, normal spine, those would be represented by rectangles, but in a scoliotic spine, they'd be represented by trapezoids to indicate that side bending and rotation. The exercises also target auto self-elongation with the cues to make the convexities forward and inward, and concavities outward and backward. They would apply these corrections to activities of daily living. And this is actually one of the more research studies, so there's been a lot of benefits associated with it. It's been shown to increase back muscle strength, breathing function, pain, quality of life, self-image, curve progression, Cobb angle, and even surgical prevalence. So this is a very well-respected study, especially in the European countries. The next approach to come about was the scientific exercise approach to scoliosis, or the SEAS approach. It targets self-correction reflexes during activities of daily living through neuromotor training, which basically means balance exercises. The exercises involve 3D correction during distracting situations with a series of 4 reflective questions afterwards. Is my spine supported and not relaxed? Is my body more symmetrical than it was before? Am I able to maintain that correction? And when I relax, do I feel myself return to the original position, or did I lose that correction somewhere along the way? It can be used for bracing with mild to moderate curves, with bracing for moderate to severe curves without bracing for mild to moderate curves. And it's been shown to improve the Cobb angle by 5.3 degrees. So this is also a pretty well-respected method. Then came the Barcelona Scoliosis Physical Therapy School in Spain, or the BSPTS. This is largely based on the Schroth method. The exercises are the same, the rotational angular breathing is the same. The big difference is that it has a psychosocial component, so it's big on the avoidance of false fears for patients with a mild scoliosis. So in terms of research and evidence, it credits the Schroth method for all of its evidence. So keep that in mind. On the complete opposite end of the spectrum is the Dobomed method. This one does encourage sagittal plane extremes, especially kyphoticization of the thoracic spine and lordotization of the lumbar spine. It also cues patients to align the shoulder girdle and pelvic girdles, which is different than most of the other approaches. Now, unlike the other ones that require rotational angular breathing, this one uses phase-locked respiration, which I'll talk about in a few slides. Now, because it does require a lot of cooperation, it's not recommended for small children. There's also 3 phases to this approach: the forward bending phase, the preparatory phase, and active 3D correction phase, each one building on postural corrections with more effects of gravity. So the first one puts positions of gravity eliminated, then some effects of gravity, and then the full effects of gravity. Of all the methods, this one shows the most improvement with respiratory function, but it's also been shown to improve the Cobb angle, the vertebral rotation, scoliosis progression, and thoracic kyphosis. In the United Kingdom, the side shift method is very popular. It's also based on the Schroth method, but in children, it teaches you to overcorrect the lateral curvature. In adults, they teach you to correct just to midline. This also has a big commitment to it. Exercises must be performed at least 30 times per day. It relies primarily on the flexibility of the scoliotic curve, so someone who has a very rigid spine would not benefit from this approach very much. There's also not much evidence for this approach. The couple studies that have been done concluded that this was a useful option, but they have not determined yet if this actually improves Cobb angle or any of those other measures. The most recent method is the Functional Individual Therapy of Scoliosis, or the FITS method. This one takes pieces from all the other methods and combines them, so you get a very individualized approach with some really complex and asymmetric exercises. It incorporates sensory motor balance training, myofascial release, and 3D correction in both static and dynamic postures. And it's been shown to be significantly effective in a short period of time for children of all ages, regardless of Cobb angle, which is kind of a big deal with scoliosis. But the best results are attained with 10 to 25 degree Cobb angle, so it's important to refer your patients early on in the process. So, that was a lot of information kind of all thrown at you, just talking about the 7 different schools. But now we'll get to the fun part, the sample exercises. My point is not to teach you per se to do each of these exercises, but to show you what the patients would be doing and why that would apply to our treatment principles. So if we go back to our treatment principles, we've got that 3D self-correction. So here I have pictures from both the Schroth method and the BSPTS, which is the one that's basically the same thing as the Schroth method. So the first picture, we see the patient using external supports, a wall ladder, to initiate an isometric force to correct their posture. In the second picture, we see basically the same thing, but with the patient stabilizing against their own body to correct their posture. here the patient would be cued to push the concavities outward and backward and convexities forward and inward until they reach a symmetrical posture. Now we can make these exercises more or less difficult. Again, in the Schroth method, they have a very popular exercise called the prone exercise, where all the concavities are supported with towels or bean bags or foam roll. So here in this picture, the concavities are indicated with like the green half circles. Convexities have red arrows. The blue arrows are traction, and then the red circles indicate activation of the right iliopsoas and traction of the shoulder. So this would be done to correct a double curvature in this patient. On sort of the opposite end of that extreme, the side shift method has a similar exercise to correct a double curvature, but the patient is cued to lift one ankle to correct the lumbar curvature and lean away from the thoracic curvature. So one of these is definitely easier to set up than the other. Then we have training of activities of daily living. So this is a picture from the C's method. The patient is cued to correct their posture in sitting, sitting while preparing to stand, standing, standing leaning against a wall. A lot of the other methods will also incorporate reaching up into a cabinet or sitting at a desk chair, learning to use one armrest versus the other to support their spine. Of course, this corrected posture is useless if you can't maintain it throughout the day. So to stabilize your posture, we use a lot of balance and proprioceptive training exercises. So this picture is from the Lyon approach. The patient is sitting on a Swiss ball or standing on a balance board. So this trains your core musculature to help stabilize your spine, but it also improves proprioception, that awareness of where your body is in space, so the patient can better recognize, am I in a supported posture, or am I kind of falling back into my scoliotic habits? And again, we can make that more or less complex. The FITS method uses a variety of balance exercises and equipment. So you see things like foam rollers, dynadiscs, Swiss balls, and a bunch of different positions. Training the core musculature, but also training that proprioception and balance. And then things get a little more tied up here. So again, the FITS method, if you remember, that's the very individualized method where you get some pretty complex exercises. So each of these patients has a different scoliotic curve. So you'll see the TheraBand used differently for each patient. This is where that extensive training really comes in, and why I'm not teaching you to do any of these today. And we also have patient education or corrective breathing. This is that phase-locked respiration from the Doberman method. So the patient is on all fours quadruped to stabilize the rib cage above the shoulders and the pelvis. The physical therapist applies gentle overpressure or manual cue on the concave side of the rib cage during inspiration and on the convex side during expiration. So they're really asking the patient to fill both lungs equally, again, trying to change the shape of the rib cage from the inside out. These respiratory techniques are nice because they can be done both with and without the brace. Many of these braces include holes over the concavities and extra material over the convexities, so it prevents movement of the convexities, but allows movement over the concavities. The PT can then apply pressure through those holes to the concavities to help the patient fill both lungs equally. Okay, so those are the sample exercises that I have for you, and just sort of an introduction to physiotherapeutic scoliosis specific exercises. If you're interested in more information, I recommend the Society of Scoliosis Orthopedic and Rehabilitative Treatment website. It's SOSORG, it's at the bottom there, .MOBI. They have a lot of free research articles available comparing PSSC to other treatments. They also have this really nice summary table with more detail than what I went through today. And with that, I would like to thank you all for coming here, and a special thank you to Dr. Alba J. Deacon for mentoring me these past 10 weeks, and the rest of the Marquette PT staff for being such a blast to work with. What questions do you have for me?
We got a question about for these various schools and the braces.
Mm-hmm.
Do they rely typically, like on an orthotist then that works with the PT and then also the physician that's part of the Zoom approach?
Yes, they do. Yeah.
Do you know anything about the dynamic bracing, the spine core system?
A little bit. The flexible bracing, the studies show that it's good for teaching sort of dynamic movements within it and allowing for more core strengthening, but it doesn't have the same effects as a rigid brace.
Granted, So the reason I'm asking is a good friend of mine, her daughter had a very mild scoliosis, and she, was here at Children's, and they had her system. I have her X-rays pre and post, and I have her spine core system. And what I liked about it was that it was a very dynamic, elastic set of forces that was put through the body, so that, because I think my concern about this stuff is, they're with you for 30 or 60 minutes, you're trying to cue them throughout the day, but most of the time, they're probably in their curve, right? And you're relying a lot on them being able to self-cue and remember all these things that you did in therapy, and the likelihood is probably poor, actually, that they remember everything, do it enough, all that kind of stuff. And this dynamic system was a physical reminder all day, that they could move in and out of their posture, because it was like, almost like having ace wraps in certain directions, but stiffer than that. So and it could be worn under clothes, so the cosmetic stuff was not an issue, because, it was like a onesie with a few straps and snaps. But all day then, when they weren't with you, like when they were at rest, the pulls of the elastic bands kind of put them back out of their rotation. But if they needed to get to something, it wasn't rigid. So to me, that made the absolute most sense. And I don't understand why that hasn't taken off more. And with your research, I'm just curious about it. I thought that was the cat's meow.
Yeah, the article that I read about the braces actually says basically the same thing, that the PTs really like the dynamic braces, but the physicians don't.
I don't understand why they don't.
They tend to get more benefit from a rigid brace, in that it corrects the cob angle more. But functionally, there are other things that the dynamic brace.
Like things that a PT
Yeah,
would-
and she just wore it for like 3 years in high school, and she had no scoliosis by the end. She got rid of it, and it was small. It was a very small, flexible scoliosis, but it was remarkable. It's a very, very detailed assessment to figure out exactly how to wrap, things and get it on and stuff like that. But she wore it all the time too, because it wasn't uncomfortable or unsightly or hot or all those kinds of things too. So I'm surprised that it didn't change the cob angle also, but I don't know what their inclusion criteria was. The other thing I wanted to ask is, because I'm the neuro person, when I see these very, very, very extreme scoliotic curves, they're usually neuromuscular imbalances. And so, because I don't do orthopedics a whole lot, I would like to know, I know idiopathic is most common, but I see the extreme stuff a lot. So how bad do the idiopathic curves get? I mean, they don't get this bad.
They can.
Really?
Yeah.
Is that
It's
usually
pretty rare,
because
so-
because the bones are misshapen rather than all the pulls? And then are we gonna change that through our forces? Is that the idea? Osteoclast, osteoblast kind of stuff, trying to remodel bone?
I don't know about remodeling the bone per se. My guess is that you wouldn't get much effect with remodeling the bone, but that you'd be strengthening muscles on one side versus the other to correct the curvature. If that makes sense.
Which makes sense in an intact system.
And one of the things that, when I was in my old pediatric practice, that we would look at too, that would maybe be a bigger predictor of who is going to advance to a higher curve, like that with idiopathic, was following when was the onset and degree of their scoliosis in relation to, we follow the Risser sign. So it's the Risser sign is it's basically a way to document skeletal maturity by looking at the growth plate on the top of the pelvis. So there's 5 stages to the Risser sign, and so I didn't have too many of those in my practice that were that bad as idiopathic, but usually you can see them early on. You can kind of almost predict who are more likely to advance to severe, because they'll start curving at like a Risser 1 or a Risser 2, and then they still have several years before they're they're going to hit skeletal maturity. So much more time to advance and progress. So usually we were more aggressive about getting those folks in. One of the things I was thinking of about talking about the dynamic bracing, some of that, and this is not a terrible slam on my orthopedist friends, but the quality of the research a lot of times too, you think about kind of bias and who they're selecting, and
Right.
You know, I
Right.
think about like spondies,
Mhm.
and you've got, you know, Lionel McKaylee in Boston, who is the big proponent of bracing for spondylolysis. Developed the Boston brace, so you have to
Right.
kind of look at it from that
Right.
standpoint too, is what kind of biases are we having in terms of,
Right.
and that's tough. I mean, it's just a tough thing to study in their defense, you know.
You know, I'm not sure if I missed, I know that bracing is part of, or in surgeries, so in terms of these methods, would they still be applicable, or are they just modified, or are they just not as good candidates for some of these methods, like post-surgical? I'm thinking of somebody that I had, and she was a freshman last year. I'm sure I'll see her in and out based on her schedule over her course here at Marquette, but, you know, young gal, and just, yeah, I mean,
Yeah, so a
has
lot.
had multiple surgeries and has had bracing.
Mhm.
They're still watching her a little bit because she's 18 and is due for a hip thing, you know, so it has all these other implications. I mean, she's very positive still about everything, which is great. But, you know, I'm just seeing this, it's like, okay, based on what I try to introduce and where I can go with her next time I see her, so, I don't know. So these methods?
Yeah, so a lot of these methods treat adolescent idiopathic scoliosis, but they do have like sort of progressions or modifications for adult scoliosis as well. And again, sort of modifications with bracing or without, with surgery. without.
Post-surgical, like you already have brought, but just still trying to do as best you can to.
Yeah, so that,
modify.
I'm sure at least one or two of these would still have modifications for someone post-surgery, even as an adult.
Right,
Probably the Schroth method would be your best bet.
okay. Yeah, I mean, I'll definitely be looking at that website.
Yeah. Other questions?
I was surprised you could get them to inhale on one side and like one part of one lobe or something. I found that I was a little skeptical
Yeah.
about that part.
It's a little optimistic.
Yeah.
I thought, really, like,
Was my
can you
opinion.
breathe
do a lot.
in?
No, QA can do a lot.
Yeah,
I
I mean,
have
I
some
taught
patients
people
that-
how to breathe, first they have to learn how to breathe diaphragmatically, but I taught them how to move their breath into different, parts of their chest cavity, abdominal, their lower, upper, circular.
I get like, not the accessories,
But-
diaphragm, but like,
And
one
that's what I,
side or the other.
that's what I
like-
mentioned it's
It's-
doing, it's
it's-
visualization
And
to
then,
help
and tactile
posture,
cueing,
yeah, that it's not,
tapping.
you're not actually changing the flow in each lung, but
Why
you're
would you do
cueing
it if
them
you-
to posture and to use accessory muscles on that side. I don't know if you're really necessarily changing volume, but I think it's a visualization is my,
But you could improve and expand the intercostals and, you know, just enhance
Yeah.
that, but tapping, I mean, it's part of facilitation. just
Right.
kind of
It's always-
Visual for both.
I think you usually take the path of least resistance. I have a lot of patients that come in with like stuck ribs, and if you look at them take a deep breath in, the side where they're stuck on isn't, you know,
Right.
moving much at all.
Sure.
So
Thank you.
I kind of visualize it's something similar to that, where you're literally trying to get them to get everything.
I get that. I think it was the picture where there was a brace and like a little hole in the brace,
Whatever.
and they're like, breathe here. I'm
Breathe
like,
through
yeah,
it.
like their hand goes like all the way around. Like, yeah, I was just, that seemed a little extreme. Like, I totally agree with what you're doing, and I know what you're talking about too,
Yeah.
but some of that very focal, like, that just seemed
Yeah.
a
Not
little
everyone.
much.
With that brace in particular, there's extra material over the convexities, so that it's held stiff over
Right.
that part. So if you take a deep breath, the only areas that will move are the parts that have the holes over them.
True, but you've got a rigid rib, you know, like,
Right.
it
No,
just
they
seemed like
expand, I mean, they kind of do kind of rotate and kind of.
Not if they're held in place the whole rest of the way around by a
I
brace,
think
you
kind of
know.
move with, like, the tiny little costovertebral and
Uh-huh.
sternocostal junction, I mean, they're still kind of expanding.
But you've got a brace that doesn't allow them to
Well,
do
it's
that
not stabilizing at the junction.
at this little
so-
spot, you know.
Yeah, so there's still a little movement that can occur.
Well, if there is, I'm glad there is. Then let's maximize it. If you guys have way more experience doing that than I do, it's just thought, and I know what you're talking about, like if you've got, I had rib fracture, so I know very well, it was not, I was doing everything I could not to expand that side, but like part of a rape? Like, that was the part that I was saying, I
Yeah.
just was kind of wondering about. So, you were very composed. This was very clear, you had good information.